Tonight, welcome to tonight's ASCS Virtual Fellows Conference. This is a 16-week virtual program spearheaded by our president, Dr. Bill Levine. Tonight's session is a young, painful proximal humerus malunion after ORIF. Dr. Mazaka and myself as education chairs will be monitoring their chats. Our moderator tonight is Dr. Andrew Neviaser, and our panelists are Emilie Cheung, James Kelly, and Mike Khazzam. And with that, Dr. Neviaser, I turn over the program to you.
Thanks, Rajan, and thanks everyone for joining us. I hope everybody is safe and life is getting somewhat back to normal. We were tasked with what I think is one of the more difficult problems that we face in shoulder surgery. And I think we're going to accentuate a few things about treating proximal humerus fractures tonight, and really accentuate the idea that you get one good opportunity to fix a proximal humerus fracture in a young person. And if that goes wrong, there are very few options to preserve the native shoulder going forward. So when you take care of these, you really have to do a good job, get an anatomic reduction and adequate fixation, or you're going to end up with these very difficult patients in your clinic, and no one really wants to see that. With that said, we're going to move on to our first case, and Dr. Emilie Cheung will be presenting this from Stanford. You guys seeing this okay?
Andy, all we see is your screen right now.
We only see the welcome screen.
You gotta switch over to the PowerPoint.
Got it. How about now?
No.
Now?
Your screen. Yes, we're good now.
Okay. Is Emilie, are you here?
Can you hear me?
Yep.
Okay, great. Thanks for having me, everybody. So we're starting off with our first case, and this is a 61-year-old female who presents 2 years after having sustained a left proximal humerus fracture at an outside hospital. Her chief complaint is pain and stiffness, and she did have physical therapy after her surgery and currently only takes Tylenol. Past medical history is listed here. And on exam, you can see that she has a well-healed anterior deltopectoral incision without any fluctuance or any concern for infection. As you can see here, her range of motion is extremely limited, both active and passive. Next we'll show her imaging. Oh, I'm sorry. On exam, just to back up a little bit, one of the things we always look for is, even though patients present very stiff in these post-traumatic or post operated on, shoulders, check that not only because they're not able to move very well, I like to have them isolate the deltoid at least so we can assess axillary nerve function. So on exam, I'll typically have them, go like this and do the chicken wing so we can assess that the deltoid's firing. And her range of motion was limited, due to her previous surgery, which you'll see in the later slide, and stiffness. And otherwise, she is neurovascularly intact. So here is her imaging. You can see here that she has proximal humeral locking plate. And you can see that on the image on the right, it's not projecting totally well, but it is showing that she has varus collapse. And so the neck shaft angle is in varus, in addition to some collapse of the humeral head consistent with avascular necrosis and malunion. On the axillary view,
Can you point those findings out for us, please?
yeah, sure. Are you able to see?
So here's, I think, one area of avascular necrosis. You can see she's got a dent in the ball. And then you can actually tell that there's some varus even on the axillary view because you see the head separated from the shaft. You should see a nice curvature of the medial column on this side as well. It doesn't look so bad on the AP, but she is in slight varus, and you can see screws protruding through.
Yeah, the other thing I like to point out, Andy, is on the axillary view, what you see is that the greater tuberosity is scarred. It looks like it's healed posteriorly relative to the humeral head, which is very common in these situations because the pull of the rotator cuff tends to displace that greater tuberosity fracture posteriorly. And it's hard to capture that fragment when you're doing the initial fixation unless you put sutures through the rotator cuff and make sure that tuberosity is reduced, is optimized in position at the time of fixation. So wanted to poll the group now and see what your thoughts are on treatment of this woman.
So, Jim, what are you going to do for this lady when she walks into your office? Is there anything else you want to know?
I think it's important to evaluate for infection. I usually try and aspirate these. I don't know if Emily mentioned that or not, but I think the problem here is that she's got avascular necrosis in a non-union, well, malunion. And for this particular patient, I would pretty much be going towards arthroplasty. And I think the most successful arthroplasty in this case is going to be a reverse. I know sometimes people consider correction of malunion. Obviously, that's not a possibility to solve the problem because she has avascular necrosis. I suppose you could consider a hemi, but I think the reverse is going to work a lot better for her.
And why do you
that's where I'd be going.
Why do you think a reverse is more beneficial to her, more predictable?
Well, in these patients that have malunions and avascular necrosis, they typically have a lot of soft tissue issues, tuberosity, malunion, and with a hemi, I think from a soft tissue and biomechanical point of view, they just don't recover their motion nearly as well. With a reverse, you obviously have the latitude to do extensive soft tissue releases. Oftentimes the rotator interval anterior supraspinatus is really scarred in. That can be released and doesn't necessarily need to be repaired in a patient with a malunion like this. Same thing for the subscapularis. If that's completely contracted and limiting motion and external rotation, it does not have to be repaired in a reverse.
So when you aspirate her, are you doing that yourself in the office, or are you sending her for an ultrasound or CT aspiration? Which one are you choosing?
I do it on my own. I know a lot of people use the ultrasound, but it takes less than 5 minutes to reach into a drawer and pull out a needle and a syringe. And most of these are going to be negative, but the times you get something positive and you actually have a syringe full of pus, you know what direction you're going in. So I do it myself. I think it's much more reliable.
Mike, would you aspirate her?
I tend not to aspirate them in the office. I wait intraoperatively because even if I get something positive, I'll treat them as a one-stage revision for infection. I consider all these infected until proven not. And I take 5 cultures like I do with all revisions, and then prophylactically treat them with 2 weeks of antibiotics till culture's finalized. I don't rely on the frozen section because they're typically normal. Inflammatory markers like ESR and CRP, I always get them preoperatively. Those are usually within normal range as well. But oftentimes cultures come back positive at 7 to 10 days. And so my antenna is always up when it's a revision.
What antibiotic do you treat them with?
I use amoxicillin, and if there's a pen allergy, then I'll use doxycycline. I'm anticipating I'm going to see a C. acnes infection because other bacterial will present itself differently.
So Emilie, the one question I had about her is, where is her incision? What approach did they use? Did they do a deltopec, or did they split her deltoid or something else that I don't know about?
Yeah, that's a good question. So she had an anterior approach, deltopec.
Okay. Would it change anything for anyone if they had done a anterior lateral deltoid split?
I think for me, you have to be more careful when you release the deltoid off of the proximal humerus because the axillary nerve may be scarred down to the plate or to the superior posterior lateral aspect of the humerus as it wraps around. So you have to be extra cautious when you're peeling all that soft tissue off.
Hey, Andy, can I ask a question?
Of course.
Are we doing aspiration here, Jim, for academic purposes? Do you really think this is infected, or do you think that this is an AVN hardware failure malunion problem?
I think it's the latter, Bill, but I wouldn't say it's academic, but most of these cases for me come from outside institutions, and I just, as a matter of, mostly as a matter of routine, aspirate them. And I'll admit fully it's not that common that it's positive. But like I said, when it's positive, you know you're going to a spacer. For me, I would go to a spacer for that if it was obvious pus.
The only reason I ask is just because we know from our friends at Mayo how futile aspirations are in the shoulder, and infections can be insidious no matter what. But thanks for answering that.
A question for the panel, Andy, for all of you. Can you comment on what your typical length of screws that you use for the primary internal fixation with a locking plate? Are you trying to get your screw subchondral, 5 millimeters, or 10 millimeters from the subchondral bone? What is your thought? And then are you always trying to get a home run screw?
So I'll start and then we can just run through the panel. I definitely do not try to get it into the subchondral bone. I think it is much more common to get a gradual settling of the humeral head onto those screws and have them pop out later on. I've seen it even as much as 4 months plus in some of these if you put them too deep. So the way I do it, I don't have a particular measurement, but I will, after I pass the first cortex, intermittently fire the drill, nothing consistent, so I won't pass the second till I get to some resistance, and then kind of pound down the cancellous bone with the depth gauge to get my length, and then subtract 2. So I'm actually generally on the shorter side because of the settling. I do try to get calcar screws to stabilize the medial column if I don't have a anatomic reduction of the medial calcar. Mike, how about you?
I'm pretty much mimicking what you're doing too. I go a little bit short. I stay away from the subchondral bone because I've seen settling as well. And I try to get something that gives a kickstand screw to give some support.
Emilie?
Yeah, I'm more focused on the calcar reduction, honestly, because I feel like the medial calcar will help support the head. So I'll try and get that reduction and kind of focus more on that than the actual screw length, because that's not really going to hold, you know, as it settles, like Andy said. And I tend to go shorter on the screws. I don't go subchondral because of the settling.
Jim?
I don't have a lot to add other than in the older patients that are a little osteopenic, adding a little bit of bone graft also does a lot to support the head beyond the screws. So I do pretty much what you do, Andy, and then I'm usually adding some sort of usually cancellous allograft.
Is anybody using structural allograft like a fibula or low temperature cement or anything like that routinely? I do in probably maybe 10% of cases. And it's really, I think I'm more focused on establishing 2 columns of fixation. So I want to get that medial calcar reduced. That creates 1 column to support the head, and then I have the plate on the lateral side. And I think if I have those, I don't have to worry so much about screw length. If I can't establish that medial column, I'll use a fibula. over there. Jim, why don't we start with you? You said just cancellous. Do you ever use more structural graft?
You know, I've used fibula, but I've gotten away from it because the process to get it in, I think, is a bit, I don't want to say destructive, but disruptive of soft tissues. And so I've just gotten away from it and just used a cancellous. I'd be curious about your comments on your thoughts about if you use a curing cement, if that heat has any negative effect on the subchondral bone and blocking, you know, the normal vascular channels. I have seen an AVN right in the segment of a patient who's had that kind of product used.
Emilie, are you using
Yeah.
it?
If I was to use an allograft, I would use structural. I guess in this acute situation, I'm thinking, you know, if we have trouble with maintaining the reduction and it's a patient in whom I think has a really good chance of, or maybe they're young, but a good chance that they can heal this and it's got a reasonable shot for an ORIF, then I would still use a fibular strut. And I know it's a nightmare to revise them to arthroplasty, but if I'm trying to get it to heal and I want it, I will still do that. I'd say about in 10% of cases. It's extremely rare, but that's one of the things I keep in my toolbox.
How about you, Mike? Anything else you're doing?
Yeah, I mean, I'm using fibula strut if there's a lot of medial comminution and there's difficulty with reduction, or if there's a lot of extension distally into the diaphysis, making it more a complex fracture that allows for almost an intramedullary strut to support the humeral shaft and then building upon that proximally.
So before we talk about what everyone would do, what do you think that they could have done differently in this case to prevent this from happening? And I guess, given that we have AVN here, when do you get concerned about AVN? Let's start with Mike.
I'm concerned about AVN based on fracture pattern, age, what the soft tissue and the bone looks like at the time of surgery. So I'm always worried about it. I always counsel my patients that, you know, that die is typically cast at the time of the injury. And sometimes it's, you know, hopeful, optimistic waiting. Even in a perfect scenario, you can still get it to happen. Sometimes it's going to happen anyway.
In a 61-year-old like we have here, what's something that would make you jump straight to arthroplasty?
I would say fracture pattern and displacement. So if it's a 4-part fracture with the head dislocated, as you can see, a valgus impacted fracture with the head beneath the tuberosities, or if the head is completely displaced from the tuberosities into the axillary pouch.
How about you, Emilie?
Yeah, if it's an anatomic neck fracture pattern, 3 or 4-part fracture in a more elderly patient, I would lean towards a reverse. You know, we do have quite a few patients who are, you know, the same physiologic age and they're younger. I'd probably be more aggressive at trying to fix them. But for her, you know, she's into equestrian. She fell off her horse. I don't have the original injury films that she had, but I would have tried to fix her as well.
Jim?
I agree with Emilie, and I think it is hard to know what we could have done better without the post-reduction radiographs. With respect to choosing arthroplasty versus ORIF initially, I'm on board with Emilie. You know, 61, as I get closer to 61, I still think that that's getting younger and younger. So I think if I had a displaced 4-part fracture, and if the surgeon could reliably get the pieces back anatomic or near anatomic, especially getting the graded tuberosity in place, I would go for that for treatment for myself. And if AVN did develop, as long as the graded tuberosity and shaft remained relatively reasonable. And if you got the lesser tuberosity, great. You can still do.
Jim, I think you froze. You guys still hear me?
Yep, still hear you.
Yes, we can. Keep going.
All right, so we'll come back to Jim. All right, so let's just quickly, Mike, what are you going to do for this lady?
I'm going to discuss her options with her. You know, functionally, you can do hardware removal and see how she does. That's not going to necessarily alleviate her pain, but it'll get some of the mechanical block from the screws that are now prominent in the joint, or offer reverse shoulder arthroplasty.
All right, it doesn't look like we have Jim back, so we're going to see what Emilie did. Here's a CT scan. You can see pretty extensive AVN. Her head here is quite flat. You'll notice there are some probable changes of the glenoid as well. So she's got now bilateral disease. Anything else you want to add there, Emilie?
Well, we showed the CAT scan there with the muscle quality of the rotator cuff. So there might be a consideration in some circumstances, maybe in some circles, to do an anatomic arthroplasty on this patient.
But you chose a reverse. So what was talk about your thought process to get to reverse as opposed to anatomic there? The cuff looked pretty good.
Sure. So we talked about that. We noticed that her rotator cuff looked fine, at least on the muscle quality slices on the CAT scan. But you could see on the CAT scan also that, like you said, she has bipolar disease. So the glenoid is really abraded from all of the prominent screws. And so the other issue that I brought up earlier is the fact that she had the varus collapse, right? So it's going to be harder to get, it's going to be harder to get that anatomic placement with that and the tuberosity malunion, right? So the tuberosity is healed in a non-anatomic position, and with its associated rotator cuff attachments and the scar tissue, basically have a dysfunctional cuff. Even though the muscle looks good, the cuff still isn't functioning. So the more definitive option is to do the reverse, so we can do the appropriate releases. And I remember in her case, her supraspinatus was scarred, infraspinatus, and it had healed and scarred in superiorly above the humeral head. And in order to get the shoulder reduced, once we had the implants in, I actually had to release some of that supraspinatus scar tissue in that area in order to get a reduction. And the capsule in these revision cases is just non-compliant. It's not very mobile. And in this case, I remember it was tight, and we had to do a lot more releasing around the humerus in order to get this reduced.
Did you culture her at any point?
Yeah, so I did not believe she had an infection, and I know that there's a lot of, potential false positives in some of that research looking at C. acnes or the bacterial flora in the shoulder. So I did not think she was infected, and when we got in there, it just looked like a AVN and a post-trauma case. So I did not get cultures during the arthroplasty either.
Yeah, I would not have cultured her either. We've already heard from Mike on that. I don't know, do we have Jim back yet? Or no?
Yeah, I'm back. I'm sorry, my internet is flaking on me, Andy.
All right. Emilie, talk to us about your choice of implant, stem length, other things you considered here to choose that, press fit versus cemented, and why you chose what you chose.
Sure. I was planning to cement her, but when we got in there, she had very good bone quality in the proximal humerus. So I thought that we would be fine going non-cemented on her. and just other, I mean, I could have cemented, but I didn't think I needed to. Length of stem, this is a good question because ideally we would have liked to pass, right, the most distal screw that you see there, the most distal screw hole by 2 cortical diameters, but I elected to go with this implant system, and I felt like we didn't need to go to a longer stem and use another implant system. So
Okay.
that's what we ended up with.
And Jim, would you have, judging by what you've seen, you would have done anatomic reverse? Which one?
No, a reverse. I would have done exactly what Emilie did.
Yeah. Okay. I think we're all in agreement there. And I would say it's been my experience when you have the tuberosity non-union, it's very hard to balance a hemi and get it to work. Even if you can get it in there and they get some pain relief, their function is not what you would expect, even if you try to get reasonable alignment. So why don't we move on to the next case? And I think that's going to...
While you guys are changing, can Emilie just talk about her post-operative rehab with that patient?
Go ahead, Emily.
Sure. So my standard reverse arthroplasty protocol is what I would use in this situation. Her subscap was not repairable, it was scarred. So my standard rehab is 6 weeks in a sling, no active range of motion for the first 6 weeks, and then no strengthening until after the 3rd month. So same protocol as a rotator cuff protocol is my arthroplasty protocol.
Does anyone differ from that, or is the panel pretty much the same with that arthroplasty?
I go a little faster. I let them do assisted range of motion right away, focus on scapula stabilizing exercises, and then at 6 weeks out of the sling in active motion. And at 3 months, I let them start doing internal rotation behind the back.
I think in somebody who's as scarred as what Emilie described, I'd probably keep them in the sling for 6 weeks because I'd be worried about getting that balanced well and potential instability, because often that previously operated tissue is very hard. It's indurated and hard to make sure that you have good stability with the reverse. If it were better tissue, I let them go at a month, but not much different than Emilie. How about you, Jim?
I'm pretty much the same. 6 weeks in a sling. I'll let them do ADLs and start at 4 weeks transitioning, eating their food and brushing their teeth, things like that. And then 6 weeks no sling, off the therapy.
Okay. All right, let's move on to the next one. And Mike Khazzam from UT Southwestern is going to present this one.
Go back one slide. There you go. So this is a 53-year-old gentleman, right-hand gentleman, who presented 6 months following left shoulder proximal humerus fracture, ORIF, by an outside surgeon. His original injury was from falling during volleyball, and he never did well after surgery. He went to 26 visits of physical therapy, continued pain, mechanical symptoms. He's got deep shoulder pain, limited range of motion, can't sleep. Feels like he's continuing to get worse. No neurologic symptoms, no signs of infection. His examination, no signs of infection, incisions well healed, axillary sensations intact. And there's his range of motion, which is quite limited. And he doesn't tolerate any passive range of motion that's any different than the active range of motion. And here's his representative AP X-ray of what was presented when I first saw him. And then here's some additional select images, some more AP X-rays in different angles, and an axillary radiograph, which has some obvious abnormalities. If Andy, you can point out there, you can see there's still non-healed fracture site, prominent screws in the joint, and a very mal-reduced fracture.
Probably a greater piece there, I guess.
Yeah, Unfortunately, I don't have the CT scan of the representative images for this, but I do have I was able to get the preoperative images prior to the fixation. So you can see from the select CT scan cuts and 3D reconstructions, they basically left the fracture where it lied and put a plate on it.
Yeah, and going back to what we said in the beginning, it is really critical if you want to successfully treat proximal humerus fractures that you've got to get them anatomically reduced. And in fact, I would think that those post-op x-rays actually may even look worse than this. They've distracted the fracture and they've displaced the greater tuberosity even more than what it was originally. This actually doesn't look like a terribly bad fracture to deal with. So Jim, if this guy walked into your office, you know, he's a volleyball player with this fracture, what would you do for him? Is there a role
Well,
for
I think,
treatment?
yeah, I mean, I think you're, I know where you're driving is it, yeah, how well will somebody do with non-operative treatment? And if you go by, if you look at the head position and the tuberosity position, it's not bad. I still think he'll have a considerable loss of motion if you don't do anything. I would probably for an active volleyball player with this kind of fracture, opt for operative treatment and try and improve it. But I'd carefully talk to them about the fact that it's non-operative treatment is an option. So that's where I would go with this.
Emilie, would you consider non-opping this guy?
Yeah, if he wasn't an athletic guy, volleyball player, I would treat it, you know, definitely give careful consideration to non-operative treatment. I mean, it looks like it's invalgus. And I do worry about the mobility that he would expect being a volleyball player and being athletic. So I would also agree with Jim and I would fix it.
I would fix it. Michael, would you have fixed this originally?
I probably would have. The thing that worries me is that middle cut on the CT scan where it looks like there's a mildly displaced head split. So those always worry me with ORIF because sometimes it's very difficult to get a good reduction of that articular surface, and oftentimes they don't do as well.
Andy, as the guy with the most gray hair in this on this panel, I will tell you that the longer I have lived, this guy would do phenomenally well without any hardware, treating him non-operatively. And I don't agree that if you use any classification system, I would challenge you all on what is the indication for surgery. Maybe you say the medial displacement of the shaft, that shouldn't cause significant problems. His tuberosity is 3 millimeters above the articular surface. That can be easily well tolerated. So I would challenge you guys, you know, once you start seeing these people in your own practices long enough, which some of you are old enough, these guys can do really remarkably well.
So Bill, do you have a specific cutoff for displacement of the greater tuberosity relative to the head that drives you to do surgery versus not?
Well, between 5 and 10 millimeters of true displacement above is kind of the gray zone. Obviously, the original description was a centimeter. McLaughlin then moderated that to 5 millimeters. But I don't, you know, I think you guys have hit it on the head. You have to talk to the patient. You have to be honest. You've got to go through the potential risks and benefits. And I always ask this question to myself, am I reliably going to make their final outcome better, assuming they have no complications, no AVN, no hardware problems, assuming they have a perfect outcome from your ORIF? Are they going to end up with better range of motion and better function than if I left them alone? And if you really honestly ask yourself that question as a surgeon, you will start coming on the other side of that equation when you see how much worse we make patients since the introduction of the proximal humeral locking plates, right? The complications are brutal. So anyway,
All right, so now we are here. And Jim, do you want to give us a critique of how you would have done this differently?
Well, this looks like, an open internal fixation. I don't think that they put the pieces back together. And it's hard to say whether their screw was too long on that axillary or whether that's just settled. But if I were to do this, I think if you, on the CT scan, you can clearly see area of hypodense area bone loss right in the middle, underneath the head, right where the major, right in there. So I don't know whether they use bone graft or not, but you need bone graft to get that supported. You need to get the head back matched up where the calcar is, and then bone graft to put the plate on the side of the humerus, and then that will correct, push everything back in alignment. So essentially it's reducing it, bone grafting it. All these cases, I always put sutures in the muscular or in the tendon bone junction and lace them through the plate. So just using the basic fundamentals of putting a fracture back together, I think the surgeon would have had a better result.
Jim,
Patient
what
would have had a better
bone graft
result.
would you use?
What kind of bone graft? I'm sorry. Is that what you said, Gus?
Yes, Jim. What bone graft would you use?
Yeah, I almost always use cancellous chips. I find it they're nice and easy just to kind of stuff into the gap there. After you get the reduction, you usually have a void. Stuff them in there, and I like to see some stability after I've put the bone graft in there, and then at that point put the plate, the screws, and tie the sutures.
I think this fracture lends itself very well to being plated. I don't think I would use bone graft, but that whole proximal piece is kind of tipped into valgus, and it's just asking for the plate to kind of push it back up into varus. I think this would be a good one to use the plate as a reduction tool. It's important to recognize the pattern of these fractures and know that your reduction maneuvers for a valgus fracture are very different than your reduction maneuvers for a varus fracture. And when you're approaching these, if you want to do a good job, you have to plan that out beforehand. And I know the NEAR classification is very popular. I think the RESH classification is much more useful because it breaks these fractures into their fundamentals, which is either varus or valgus, and that'll help you with your reduction. So for the fellows out there, if you have not read that classification, it's a great one. Make sure you look at that. Is this guy getting aspirated? Let's just go quickly, yes or no. Emilie, are you aspirating him? Yeah. Jim, aspirating him?
Yes, I would.
And Michael, did you aspirate or?
I did not aspirate preoperatively. I aspirated intraoperatively.
Okay. Is anybody doing a revision ORIF? Is it possible here? Emilie.
So, are you able to hear me?
Yep.
Okay. Thought that was on mute. Looking at the imaging that we have, it looks like, the head is still alive, so I guess that's a fair question to consider. And there is an area there, clearly not united, but the thing that bothers me is the location of that tuberosity, right? So I feel like this patient is going to have difficulty with overhead motion, even if, you kind of just subtracted everything below those locking screws and got that section to heal. If this was to heal, you'd still have that difficulty with range of motion because of the relative position of the greater tuberosity and the rotator cuff dysfunction. So unfortunately, I would probably not do a revision ORIF in this situation. Now, I have in some cases where the fracture line was much lower, and it, and then we're not really in the proximal humerus anymore. For like a two-part where the greater tuberosity isn't affected and the fracture is much lower, like maybe where, where that first shaft screw is, maybe those sorts of cases, I might consider doing that, but not for this. It's too proximal.
So what would you do? Anatomic, hemi, reverse?
Yeah, so I would do a reverse in this situation.
Okay.
For
Jim,
the same
revision
reason.
ORIF for reverse?
I don't think revision to ORF would help this gentleman. I don't recall exactly what his range of motion is, but I might consider, taking out that long screw that's sticking into his joint, and maybe a little capsular release. It's going to be limited goals, and I don't think it's going to be very effective. But if the screw is causing him a lot of pain and it can be taken out and he can move his shoulder, that's a somewhat simple solution for the short term before he gets an arthroplasty down the road.
Is anyone concerned that it's only 6 months after his initial operation and we're talking about doing an arthroplasty? I think I'd be inclined to do what Jim just said and take out that one screw and see. But Michael, let's see what you did here.
Yeah, so we discussed that. The patient was inclined to have one surgery and be done. We discussed just taking that screw out, giving more time for that distracted aspect of the metaphysis to heal in. And he said, if I'm going to have another surgery, I want to be one and done. So I elected for reverse. I tried to capture the tuberosities and repaired them as I would for an acute fracture. So I mobilized them as much as I could and then repaired them to the implant with suture, and then tried to lateralize the glenoid side as much as possible to restore some of the deltoid wrap.
You did both lesser and greater tuberosities?
Just greater. Lesser was not mobilizable.
Okay. Emilie, do you always repair the tuberosities, both, one, or never?
You mean in the setting of with the revision?
Yeah, revision or even acute fracture.
Yeah, so in the revision setting, if the tuberosity is malunited or I feel like it would impinge on the posterior prosthetic, it might, if it impinges there, I would probably osteotomize it, and oftentimes it's a non-union. So in those situations, I would definitely save the tuberosity, the greater tuberosity with its associated rotator cuff attachment, and make sure that during the trialing, and I'm doing a reverse, I make sure that that's going to reach over and heal, or at least reach over so that we have the best chance to get this lined up so the patient could potentially heal that. So when I'm doing a reverse for acute fracture, I do that. I do pay attention to the lesser tuberosity in the setting of the acute fracture. And I'll preemptively drill holes in the cortex to receive some of those superior to inferior trajectory sutures, those high caliber sutures that are containing the cuff and the tuberosity. Yeah, that's a very important part. I'm glad you asked that.
Does anybody use
what allows the patient to rotate better, right, and have better mobility afterwards.
Yeah, the hardest part of these is restoring humeral length, and if you don't restore humeral length, you get instability that's very difficult to treat.
So,
Yeah.
Mike, what are some tips that you guys have on knowing when you've restored length?
So helpful tips: if the tuberosity still looks like a good anatomic piece of anatomy, you can use that to measure off of. Otherwise, I'll get full-length humerus x-rays of both sides to measure length so I can restore the length as close as possible.
About when you're in the OR, is it just reduction of the tuberosity that you're using?
Yes, I try to look at the remaining bone and use the tuberosity as a guide.
Okay. Jim, how about you? How do you know you've restored length when you're converting to a reverse?
I'm not sure that I know or can really predict that in advance. I had gone through a stage in my life where I obtained the X-rays preoperatively of the contralateral side, but at the end of the day, a lot of these revision cases are so scarred that the scar doesn't allow you to achieve the anatomic length that you want, at least for me. I think the tension that you try and get tension and proper tension and stability in the operating room using the same principles that we always use: conjoined tendon, soft tissue tension. The graded tuberosity can be put back on, then that's a key component for function later. Sometimes it can't. It is important that if you're going to try and reduce the graded tuberosity, that you don't lengthen too much, because then it becomes almost impossible to get the graded tuberosity back on. And one other thing for the fellows to know is that if you approach a case and you have a tuberosity that's wrapped all the way, graded tuberosity that's wrapped all the way medial, posterior, sitting on the back of the on the glenoid and the infraspinatus fossa, for me at least, I've had very little success at mobilizing them and bringing them back into place.
I also think that those malunited tuberosities are a source of instability because they impinge on the back of the glenoid when you externally rotate. So sometimes I burr it down, not taking off the cuff part, but just taking off the bone part, so it's not so prominent.
Yeah, or you can take out the tuberosity, but it's not a, it's time consuming and challenging sometimes.
So 3 years, here's some data. Very good forward elevation. Internal rotation, a little bit limited, but good ASES total score.
Yeah, that's the hardest part in these, to predictably restore activities of daily living behind the back in these revision cases of malunited fractures.
So what version do you put your stem in?
I put everybody in 20 to 30 degrees of retroversion.
Why?
I'm trying to restore the proximal humerus anatomy relative to the forearm.
Okay, Emily, what do you do?
Yeah, I use 20 degrees retroversion from the forearm axis.
And the reason behind 20 degrees?
Well, it's anatomic, so that's what I was taught.
So we're trying to reproduce anatomy with flipping the ball in the socket. Jim, what do you use?
So, yeah, so when I started doing reverses, we did them in 0, and then we did them in 10, and then we did them in 20. And so what I do, if there are tuberosities that define the version of the head, I use that and try and leave it in their native version, as long as it's not excessive. But other than that, I put the arm in neutral rotation, and after I put the glenosphere in there, I want to get the humeral component pointed towards the glenosphere so they have some sort of semblance of symmetric external and internal rotation. And you know what? Usually it's 20 or 30.
Okay. All right.
Question from the chat room.
Yeah.
If you encountered intraoperative that when performing reverse, they cannot bring the greater tuberosity in place and the posterior cuff is missing, would they add a tendon transfer at the time of the reverse?
That's
Emily?
ambitious, I would say.
Yeah, so in this, you mean in the revision setting?
Yep.
Yeah, sometimes the greater tuberosity might not reach. I forgot to mention earlier, though, that if we're trying to get the tuberosity to heal, if we had to do an osteotomy of the tuberosity, I would use a fracture stem. I think that makes a big difference. But if I could not get it to reach, I would excise it before I would consider doing a tendon transfer, honestly. I think with the scar tissue there, I think if it doesn't reach, there's the axillary nerve there posteriorly. Sometimes that tuberosity piece, as you mentioned, heals and scars into the posterior capsule. and it is right in axillary nerve territory along that region. And I would probably do a subperiosteal dissection and take out the impinging bone there, because in the revision setting, sometimes the rotator cuff doesn't allow it to have that normal excursion that we encounter in a fresh fracture situation. So I'd rather do the excision.
Michael, are you doing any tendon transfers if you can't fix the tuberosity?
I've not done any in a revision setting for a fracture.
I would be more inclined to go to kind of one of the smaller proximal humeral reconstructions if I have to excise the tuberosity than a tendon transfer. I don't think doing the lat transfer successfully restores external rotation as well as having a tuberosity there. And I'd be a little more worried about instability if I didn't have the tuberosity to kind of wrap the deltoid. But I think those proximal humeral reconstructions with the large kind of bump on the side wrap the deltoid nicely and prevent that instability. Jim, how about you? Are you doing tendon transfers in these?
No, like I kind of mentioned, I think that's very ambitious. The soft tissue challenges, as Emilie alluded to, I think prevent the ability to successfully achieve a tendon transfer to restore external rotation in a revision situation. And in fact,
uh-oh, I think we lost him again. Just when he was getting to the surprise ending. Well, the next case is his. So we'll give him a second here. Any other comments about this case? I think everybody was on board with arthroplasty at some point. Okay.
Andy, why don't you just present his case?
Yeah. So, all right, so we got a 48-year-old right-hand dominant triathlete bike accident. And you can see the injury films here. So he's got fracture and dislocation. And underwent acute ORIF. Here are some intraoperative films.
sorry, Andy, I'm back.
Oh, all right, we're just going through your case.
Yeah. Yeah. So you saw the patient with this displaced anatomic neck, surgical neck graded tuberosity fracture, 48-year-old. I'll call him a young guy because he's younger than me. Right hand dominant, left shoulder injury, May 2014. And this was done in a trauma center locally. You can go ahead and advance the slide. This is intraoperative C-arm, and then advance the slide from here. I just comment that I have, this is a case from 5 years ago, so I don't have every single x-ray and chart note. These are the best x-rays that I could come up with to represent what the post-operative status was. He was seen about a month after this surgery by another surgeon in our community who recommended just watching this. And then he did poorly. And then next slide, please, Andy. He came to see me in September. So now we're 4 months following. He's a certified public accountant. He had a surgery done by a surgeon up in Davis, who's no longer there because he went on to practice. His complaints are limited range of motion pain. Physical therapy did not improve him very much. His ADLs and work are okay. He's unable to swim, which he really loves to do. He's got limited motion, decreased strength. He takes occasional Norco. He's a big guy, 5'10", 245, BMI of 35. He can flex to the horizontal. He has no active, he's external rotation to neutral, essentially with the arm up in the abducted position. He can only move 10 degrees up and down. He's got a healed scar, intact deltoid, intact external rotation sign. I can't test the lag sign very well, but I think it was negative. internal rotation 4+, and I can't check a belly press because he's too stiff. So if you go to the, yes, this is his CT scan that was done. And so I just try to give you representative cuts. You can see, Andy, if you don't mind pointing out the displaced greater tuberosity on the left-hand side. Looks to me like the lesser tuberosity may not be healed on the left-hand side in the front of this. Yeah, there too as well. Clearly a valgus head if this cut was properly aligned. So this case has got a couple different steps. I apologize that I gave away the first part of the plan there, Andy. But I considered what to do with this guy at 48. And I just figured, well, if maybe I can accomplish something, getting some motion back without going directly to an arthroplasty. And so I went in and arthroscopically did a capsular release, and I tried to move the tuberosity back into position, but unfortunately the two screws from the plate were in the way. So I did a small, end up doing a small open reduction of that tuberosity and remove two screws to get it back in place. And so this is essentially what I found in the operation. It's a mobile, his greater tuberosity was mobile. He had condylation on both sides, and he had a small area of collapse of his humeral head, 2 centimeters. So anyway, what did I accomplish? Nothing, unfortunately. And he had persistent pain and functional impairment with the same range of motion, the same strength after this. So you want to just keep going, or we want to stop for questions, Andy?
We only got a few minutes.
Okay. Okay. So, yeah, about 5 years ago, again, I went forward with. So he was now, I think, about a year after his injury. He was kind of sick of it, and so we went forward with the reverse arthroplasty, as you can see. What I found in there was just what Emilie and Mike have described with their patients, which is a lot of dense scar. He did have a lesser tuberosity fibrous non-union, and interestingly, the greater tuberosity had healed. I chose a similar implant to Emilie. I do it a little bit different. The upper part of this implant, if you can point to the upper part of the implant for me, Andy, it does have a coating on it on the stem portion. And so that's where you're going to get your on growth. But I wasn't super confident about the bone quality being able to be stable and get on growth. So I put cement distally. It's sort of a hybrid fixation, cement distally, and then press fit it proximally. Hopefully that would have some on growth and some long-term stability to it. I did culture it only twice, which I would tell you, if you're going to culture, you need to probably culture 4 or 5 times. And I got 2, broth cultures of one culture, 1 colony, 1 culture, 2 colonies of P. acnes, which turned out to be not an issue. I treated the guy with 6 weeks of oral antibiotics. So I think the most interesting thing about this case is that, and I promise, Andy, you can back me up on this. I gave you this case like 4 weeks ago. Go to the next slide. These are his 2-year photos. And then the next slide, I got this letter from him. Well, let me show you. This is his. I got a letter from him. Well, here's his. Sorry, go back, Andy.
Whoops. Sorry.
Oops. No problem. Right here. So at 2 years, he's activity-related pain, infrequent, no night pain, moderate limitation of recreational activity, having some difficulty with biking, very satisfied. His SANE was 75%. You can see what he's responding to on the ASES questionnaire. But he sent me an email out of the blue 4 days ago. Go down to this. He says, no, keep going right there. Hope you're well. I wanted to touch base with you about an event I am planning on partaking in next year. I'm signed up to participate in the Atlantic Challenge, rowing across the Atlantic Ocean. The row is 3,000 miles from Canary Islands to Antigua. I believe I could do this row, as rowing is one of the few activities I can do without aggravating the shoulder. I can no longer swim without real pain, and biking is uncomfortable, approaching the painful, but rowing is fine. I anticipate I will need your consent. I assume that they will require this. As you may or may not remember, you did a reverse shoulder replace on me 5 years ago in July of 2015. just think of using this in a conference presentation and in the study I'm already included in. So I thought this was classic.
So what'd you tell him?
I haven't responded. I'm waiting to find out from you what I should tell him. Maybe that's the next question.
All right, so next round of question. Who lets him row? I would let him go. Mike, you let him go and row?
Sure. Rowing's good. It's good for the scapula, right?
Yeah. Emily?
I'd say let's enroll him in a study.
Yeah.
Let him row and see what happens.
It doesn't matter what you
Atlantic
tell him.
Ocean.
Andy, it doesn't matter what you tell him. He's going to do whatever the hell he wants.
That's why I just tell him what he wants to hear.
Right.
So we are out of time, but you know, when Ranj and I were kind of brainstorming, this was one area that we were really troubled with, and it seems that it seems that this is not a problem anymore, because every case went to reverse.
Yeah, so that's it.
So that's the answer. A young person doesn't matter. It goes to a reverse, correct? Would everybody agree with that? I mean,
I actually requested, Gus, I requested of them if they had any repeat revision ORIFs that we pick those, because I figured nobody was going to have one. And that was actually the case.
So final question for the group. So would you do the same thing, if your revision ORIF was a patient in their 30s, would you still do a reverse?
I would. Emily's shaking her head. I would if I thought that's the most predictable outcome.
I agree with Andy. If I think that it's the most predictable last operation that I can provide for that patient with the best functional outcome, I would do a reverse.
In someone in their 30s?
Yeah, I would give them limitations. I wouldn't let them go crazy with it, but yes.
I think the issue really comes down to the position of the greater tuberosity. If it is malunited, the success of moving it and refixing it is, in my experience, very similar to what Jim just showed. You can get it to heal in the new position, but it never functions properly, and they don't actually benefit from that procedure. And that's been borne out in the literature as well. So if they have a malunited tuberosity as part of their malunion, you're not going to be successful doing a revision ORIF. And a reverse is a more predictable outcome than a hemi for the same reason, because the tuberosity is not going to function well mechanically. That's what I would think.
Okay, thank you, everyone. It's 7 o'clock. I appreciate your time, efforts, and we look forward to the next week's session. Thank you, everyone. Stay safe.
Thanks.
Thank you.
Bye-bye.
Thank you.
Bye.